dental session in Apan 53, and we wish you a very good morning. I'm Dr. Aksa Syuhada from Erlangga University, the program organizer of this session, and I've been involved to organize this session since 2016. As usual, dental session is the meeting that discusses updated dental science and dental case in Asia, and today we will discuss and explore orthognathic surgery from two perspectives: the perspective from oral and maxillofacial surgery, and the second perspective from orthodontics. This meeting will be moderated by Dr. Yosi Yuanita, the oral and maxillofacial surgeon from Hasanuddin University in Makassar. And before we start the meeting, I would like to introduce our speakers, committee, and participants. And I start with our chairperson today, Dr. Yosi Yuanita. Please introduce yourself to everybody here.
Thank you very much, Dr. Aksa. Assalamualaikum warahmatullahi wabarakatuh. Good day, everyone. My name is Yosi Yuanita Ariestiana. I am become a participant of the APAN since last year, since Dr. Aksa recruited me in the APAN 52, and I am now one of Indonesia's representative for the APAN. I'm from Department of Oral and Maxillofacial Surgery, Faculty of Dentistry, Hasanuddin University, Makassar. Thank you.
Thank you, Dr. Yosi. Next, I would like to invite the Dean of Dental Faculty, Hasanuddin University, Professor Muhammad Ruslin. Please, Professor, say hello to everybody here.
Hello, good day, everybody. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
I am Muhammad Ruslin, as the Dean of Faculty of Dentistry right now, and also I am oral and maxillofacial surgeon. And I would like to say thank you very much to the organization committee to invite me to collaborate in this event today, and according to the Apan 63 event in Bangladesh. Thank you very much.
Thank you very much, Professor Dean. The next, I would like to invite Associate Dean from the Faculty of Dental Medicine, Universitas Erlangga, Dr. Andra Rizkiawan. Please, Dr. Andra, say hello to everybody here.
Yes, good morning, everybody. Ohayo gozaimasu. It's really nice to join this seminar in Apan 53. Yes.
Okay.
Thank you very much, Dr.
Thank you, Dr. Andra. The next, I would like to invite Dr. Sari Sandy from Universitas Indonesia. Dr. Sari Sandy, please introduce yourself to audience here.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. And I'm Sari Sandy from Department of Orthodontic, Universitas Indonesia. And this event in this event, I'm going to give presentation from the orthodontic point of view about the orthognathic surgery with the combination with orthodontic treatment in the adult cases. I am really happy to be able to join here, and thank you very much, Professor Ruslin, Dr. Andra, Dr. Aksa, and Dr. Yosi, Dr. Melissa, and everyone that I cannot see. A very good morning for you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. I also see the presence of the head of oral and maxillofacial surgery Department of Universitas Indonesia, Dr. Lilis Sulistiani. Dr. Lilis, please introduce yourself to everybody and say hello. Dr. Lilis, are you here? Okay, maybe I would like to invite Dr. Melissa Adiatman from University of Indonesia. Dr. Melissa, please say hello to everybody.
Good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. My name is Dr. Melissa Adiatman from Faculty of Dentistry, Universitas Indonesia. Here I'm helping Dr. Aksa organizing the 53rd Apan dental session. And I think this will be a very fruitful session for everyone, especially on the associated field. So very good morning to you all, and please have a very good discussion. Thank you.
Thank you very much. Also, I would like to introduce our engineers of this decisions. I would like to invite Mr. Tunggul Laksono from Universitas Brawijaya. Mr. Tunggul.
Everyone, my name is Tunggul Laksono. I'm the Chief Engineer of Indonesia Telemedicine that provide the TEMDEC in this Apan 53 Bangladesh. Nice to see you all. Thank you. Dr. Asa, we also have
Thank you very much.
From the Sumatera Utara.
Okay. I would like to invite our newcomer for the technical staff, Mr. Rico Januari from Universitas Erlangga. Please say hello to everybody here. Rico. Rico, are you here?
Yes, I'm here, Doctor. Thank you for the time. I'd like to introduce myself. I'm Rico Januari, and I'm IT staff on Universitas Erlangga.
Thank you, Rico, for your introduction. And the next, I would like to invite Masahiro Komatsu from TEMDEC. Please say hello to everybody here. Komatsu-san. Okay, it seems that you are not ready. I would like to invite the engineer from TEMDEC, Dr. Shunta Tomimatsu. Please introduce yourself to everybody here, Dr. Tomimatsu.
Hi, good morning, everybody. This is Shunta Tomimatsu. I'm an engineer from Kyushu University Hospital, Telemedicine. I'm happy to join this conference. Thank you very much.
Thank you. The last one, maybe I would like to invite the representation from University of Sumatera Utara, maybe the head of Department of Oral and Maxillofacial Surgery could be introducing for anybody here. No one? Okay, I think it's enough for introduction. Because we have a very limited time, I would like to ask Dr. Yosi, take your time to moderate this meeting, and everybody have a good meeting. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Aksa. Assalamualaikum warahmatullahi wabarakatuh. And good day, ladies and gentlemen, audience, distinguished participant. We meet again today in the next sessions of the APAN. Last year we've talked about the cleft, and for today's session we are going to talk about the orthognathic treatment that will be discussed in two kind of perspective, from the surgery perspective and from the orthodontic treatment perspective. And we have three speakers for this session. Allow me to introduce one by one. Professor Muhammad Ruslin, MCAS PhD, Specialist Bedah Mulut dan Maxillofacial Consultant from Hasanuddin University. He is also the Dean of Dentistry Faculty, Hasanuddin University. And we also have Dr. Gigi Sari Sendi, SP Art Consultant. She is from the University of Indonesia. And our another speaker from Erlangga University is Dr. Gigi Andra Rizkiawan, PhD, FICS, Specialist Bedah Mulut Consultant. And before we start, I'm going to inform you that every speaker will have about 15 minutes to presentation, and our last session will be discussion for about 10 to 15 minutes. For our first speaker is Muhammad Ruslin, DDS MS PhD, a professor at the Department of Oral and Maxillofacial Surgery. He is also the Dean of Faculty of Dentistry, Hasanuddin University. He was born in Pangkajian, Indonesia, July 1973. Currently, he's a professor in my faculty, and he is also a consultant from 2017. Graduated as a dentist in 2000. Graduated as a magister in oral and maxillofacial surgery from medical faculty, Pajajaran University in 2009. Graduated from residency of oral and maxillofacial surgery from Faculty of Dentistry, Pajajaran University in 2009. Registered as oral and maxillofacial surgeon, a consultant in orthognathic surgery and osteodistraction since 2017. He did a visiting fellow, a research fellow in Toyama University at Department of Oral and Maxillofacial Surgery, Graduate School of Medicine and Pharmaceutical Sciences for research under supervision of Professor Makoto Noguchi. He also performed a clinical fellow in the Department of Plastic and Reconstruction Surgery in Changeng Memorial Hospital in Taiwan, under supervision of Professor Lun Zhou Lo. And he graduated his PhD program from Department of Oral and Maxillofacial Surgery, VU University Medical Center, Academic Center for Dentistry, Amsterdam, or ACTA, under supervisions of Professor Timur Borozanfar and co-promoters Professor Bram Tuinseng and Paulo Bofano, MD, PhD in 2019. Ladies and gentlemen, please welcome Professor Ruslin. Professor Ruslin, your time for presentation is about 15 minutes. I will remind you at the last 5 minutes. Thank you.
Thank you, Dr. Yoshi, for your introduction. Good day, everybody. All participants for our event today is the 53rd Apan Dental Telemedicine from Kyushu, Japan, with collaboration some university in Indonesia. I would like to say first to the organization committee to give me chance include in this event, in good event. And today I would like to share and repeat my topic according to the surgical orthodontic and basic treatment and experience in our institution. Let me share my PowerPoint, please. You can show my PowerPoint?
Yes, Professor. It's shown.
Yeah, and we know each other. Is the dentofacial deformity is we describe as a type of the deformity that affected primarily the jaw and the dentition. This result from an even growth pattern between a mandible and maxilla. Next. And if you saw this table, we can show the type of deformity like long face, short face, facial asymmetry, bemaxillary protrusion, and also we can show what is going on in the future of the clinical aspect. For example, for the long face, we can found is gummy smile and or increasing the lower facial height, and also we can make associated with the skeletal problems. So for example, if the type of deformity is short face, we can found in the clinical is the reduce lower facial height, and also we can make like association with the skeletal problem is vertical maxillary hypoplasia. So I think this is table is very important to make divided from the type of deformity features, and also we can show the associated the skeletal problems. Next. So the study of dentofacial deformities is based on the 3 different sequence analysis. The first is direct and photographic clinical facial analysis, and the second is the intraoral and dental case analysis. We can found with 2 ways, is with intra-arch relationship and also with inter-arch relationships. And the third is cephalometry analysis. Next. So the basic components of dentofacial deformity, if we understand dentofacial deformity, a clinical case, and can be made easier by the identification of the basic components. That is anterior vertical axis or deficiency. Is the second is class 3 or 2 sagittal discrepancy, and the third is transverse discrepancies and asymmetry. This is the clinical view of the anterior vertical axis. If we saw the fig A is the clinical case of the anterior vertical axis with frontal view, and also in the oblique right and profile, and also we can show the form of the cephalometric tracing. This is also the anterior vertical deficiency, the clinical view of the case of vertical deficiency. We can show in the frontal, oblique, and profile, and also the cephalometric tracing. This is view of the clinical aspect of class 3 sagittal discrepancy from the frontal, oblique, and profile, and also the cephalometric tracing. So we can show it's a little, very differences from the others classification. Next. And this is the class 2 sagittal discrepancy. If we saw the clinical, we can show the dentofacial deformity class 2 with frontal aspect, oblique, and also the profile view, and we can show also the cephalometric tracing form. This is some of the transverse discrepancies and asymmetry for the view of in clinical aspect. We saw the related to the transverse atrophy of the maxilla and severe negative tooth arch discrepancy in the upper arch. We can show in the A figure is oblique and also frontal profile view, and we can show the cephalometric tracing. So we know the type of dentofacial deformities in mandible is like mandibular prognatism, mandibular prognatism with the open bite, and mandibular deficiency, relative mandibular deficiency, and also absolute mandibular deficiency. This is the form of the mandibular prognatism. The characteristic deformity is mandibular prognatism with reverse overjet. This is the key is reverse overjet. And we can show in clinical is mandibular prognatism characterized is by reverse overjet and may arise from the maxillary deficiency or mandibular prognatism, or we can found is both maxillary deficiency or mandibular prognatism. This is the second type of mandibular prognatism with open bite. So the characteristic this deformity is mandibular prognatism, and like we describe in the fig 1, with or reverse overjet and open bite that may be due to the maxillary deficiency or mandibular prognatism or both. Next. This is the third. Mandibular deficiency, and this characteristic by a mandibular prognatism that present with a convergent facial appearance and increase overjet or deep overbite. This is a characteristic of the mandibular deficiency. Next. The other one is relative mandibular deficiency. Relative mandibular deficiency is with characteristic by a mandibular of normal size that is secondary to vertical maxillary hyperplasia. This is like a clinical view of the relative mandibular deficiency. And the last is absolute mandibular deficiency. And the characteristic of absolute mandibular deficiency, which include a divergent facial appearance, an increased sagittal overbite, and tendency to the open bite, differ significantly from relative mandibular deficiency. Now is basic therapeutic goals of the orthognathic surgery or surgical orthodontic. The first is function. We would like to found functional of masticatory and also the aesthetic. If you already correction of the skeletal this harmony, we can get the aesthetic of the patient. And also the most important thing is stability. After correction, we must make sure our after operation is the stability of the bone after surgery. So also we hope the therapeutic goal is minimizing the treatment time. So for the minimizing the treatment time is we need more short time to prepare the patient to get stability of the Discrepancy or skeletal deformities. Next. Some study have reported that the most common surgical techniques to correct dentofacial deformities like sagittal split osteotomy, intraoral vertical ramus osteotomy, liver-1 osteotomy, genioplasty, anterior segmental osteotomy, or some surgeon combine some of this technique to get more stability, to get more aesthetic, and also the function. Sagittal split osteotomy can also be performed by bilateral. So some cases we do only unilateral or we do bilateral, but generally we do with bilateral. The split osteotomy was made at the region of the first or the second molar, and the teeth were placed in their plane position using surgical splints. Its condylar segment was fixed flexibility with titanium mini plates that were applied intraorally on each side using 4 monocortical titanium screws. But some surgeons also use only screw with bicortical titanium screws. And each screw was 2 millimeter in diameter and 5 millimeter in length. But for the, if we use a screw for the biocortical, we can some use screw with length is 7 or 11 or millimeter in length. Also, we sometimes we use intermaxillary fixation to maintain with a rubber elastic for an average duration of 14 days or 2 weeks for the using rubber elastic. Next. For the this is the if we perform for the sagittal split osteotomy, we can cut in the ramus area and we split the bone and we moving the proximal or distal aspect of the bone in the ramus and also in caput mandible. Next. This is a few of feature sagittal split osteotomy technique. So some bone in the ramus area we put out and then we make a backward or forward of the mandible. Next. The second technique is intraoral vertical ramus osteotomy. These procedures make a muscle, masseter muscle was detected from the lateral surface and of the mandible ramus, and we cut vertically with oscillating saw. So after we do surgery with intermaxillary fixation using 0.4 millimeter wires was maintained for a average duration of 6 weeks. This is technique not famous right now because some surgeon using with BSSO technique. Yeah, this is a type of intraoral vertical ramus osteotomy, and also we can do with extraoral vertical ramus osteotomy. But if we compare the two types with intraoral and extraoral vertical ramus osteotomy, some surgeons choose intraoral osteotomy vertical ramus because the aesthetic aspect. Next. This is a view of the intraoral vertical ramus osteotomy. So we cut the bone, ramus bone with vertical position. Next. The third technique is the level 1 osteotomy. This technique involves down fractures and repositioning of the maxilla to obtain the desired position. And then we do with rigid fixation of the maxilla when achieved using either 4 titanium mini plates, and we positioning in the posterior and anterior regions. Some surgeons put 2 titanium mini plates in the anterior regions and 2 wires in the posterior regions, or some surgeons do with also in the posterior region with 2 titanium mini plates. Yeah, next. This is a few of the technique of level 1. So we divided the maxilla with the basic skulls of the maxilla. So we divide it, and then we looking for the good position of the maxilla, and then we fixation with the screw. Yeah. So the other technique is genioplasty. This is an additional technique if we do surgical orthodontic, and genioplastic is usually performed in combination with either mandibular ramus osteotomy or maxillary osteotomy. And if we prepare to do genioplasty, the incision made between the first and the second premolars just below the mucogingival junction and extended through the periosteum. So the line of the bone incision are marked using a fine fissure burr. This is make position the marking, and then the osteotomy cut is made from the midline with a medium blade in oscillating so and fast laterally. After the result intermediate fragment is removed, the chin we do with retraction, and fierce elevator are removed, and drill holes are placed for wire osteosynthesis. And the chin segment is held in place with a bone clamp or tooth Crelly artery forceps, and then 0.5 millimeter wires to tightening and sequentially.
I'm sorry, Professor. I must to remind you that your time is 5 minutes left.
Yeah, and then this is the genioplasty form, and then this is the other technique is anterior segmental osteotomy. This is we can do in mandibular or maxillary technique for the segmental osteotomy. Next. This is the figure of anterior segmental osteotomy. Some surgeons use this way to do to achieve the aesthetic or masticated aspect. Yeah. The other complication of dentofacial deformity like infection, flat exposure, mild edge-to-edge relapse, a neurosensory deficit of the inferior alveolar nerve. This is for the specialists for the BSSO technique. For the complication in intraoral or extraoral vertical ramus osteotomy, we couldn't found the neurosensory deficit of the inferior alveolar nerve. Next. This is some case of malocclusive skeletal class 3. Next. This is before and after surgery. We can show the pre-profile of the patients. Next. This is surgical procedures. Next. And we do BSSO and also level 1. This is the result after surgery. Next. And this is lateral view before and after surgery. Yeah. And this is the panoramic view before surgery and 1 week after surgery. Yeah. This is we do with level 1 and also with BSSO technique. Yeah. Next. This is cephalometric view before and after. Next. This is the second case, malocclusive skeletal class 2. Next, this is a view of the patients with nose. This is the B view is a sweet smile. We can show the gummy smile, and then lateral view. Yeah, next. This is the intraoral view of the occlusion of the patients before surgery. Next. All patients we do with orthodontic first. Yeah. Next. This is a cephalometric. Next. And in this case, before surgery, after surgery. We do with the genioplasty with anterior segmental osteotomy maxilla. Next. This is before surgery and after surgery. Next. This is the occlusion. Yeah, next. This is also the view of the occlusal aspect in mandible and maxilla. Next. This is panoramic view before and after surgery. So we do with a segmental anterior, anterior segmental maxilla, and also we do with genioplasty. Next. This is the result, supplemented view. Next. This is, and I say the last is next. Thank you. Yeah, I think it's, that is Dr. Yosi. Thank you very much for your time.
Thank you very much, Professor Roslin. That was a very nice presentation. A very good cases. We will discuss about the cases maybe later after our next two speakers. Thank you very much, Professor Roslin. I'm going to move to another our next speaker, Dr. Gigi Sari Sandy Sumardi, SP Art Consultant, born in Palembang, March 1976, graduate as a dentist in 1999, specialist of orthodontics in University of Indonesia, graduated in 2008, consultant of orthodontics for treatment in adult patients, also from University of Indonesia in 2021, graduated his doctoral degree from University Indonesia in collaboration with Radboud University Medical Center in 2022. Dr. Sari Sandy also ever presented about the biological and clinical aspect for cleft treatment in Indonesia in Kagoshima University, Japan in August 2015. One of her publication, the last one, is the proportion of skeletal and dental components in patient with facial asymmetry encephalometry study. Dr. Sari Sandy, please, the time is yours. I'm sorry, I would like to remind about the time for your presentation, and also to Prof. Roslin before, the time of presentation actually is 20 minutes. So I will remind you at the last 5 minutes. Thank you.
Thank you. Thank you very much, Dr. Yosi. Good morning to everyone. I'm Sari Sandy Sumardi. I am here on behalf of Department of Orthodontics, Universitas Indonesia. And today I'm going to present about the treatment in the adult patient with the malocclusion of class 3, skeletal class 3. I would like to share my screen. Okay, can you see my screen, Dr. Yosi?
Yes, doctor, I can see your screen. It's very clear.
Thank you. Thank you. Now, so the treatment of adult patients with skeletal class 3 malocclusion is, So today I have the outline is the introduction and the case treated with combination of orthognathic surgery and case treated with camouflage, and then the summary. So as we know, the class 3 malocclusion is characterized by protrusive mandible, retrusive maxilla, or protrusive mandibular dentition, retrusive maxillary dentition, and maybe combinations of these components. And a normal occlusion and improved facial aesthetics of skeletal class 3 malocclusion can be achieved by growth modification, orthodontic camouflage, or orthognathic surgery. Now, the severity of class 3 malocclusion in adult cases will define whether the patient is suitable for orthognathic surgery or orthodontic treatment. Orthognathic surgery actually is divided into two types. One is the surgery, intermediate or conventional surgery, which is performed between preoperative and post-operative orthodontic treatment. And the other one is surgery first, which is the surgery performed before the orthodontic correction. The one that I'm going to present here is the surgery intermediate, which is performed between the preoperative and post-operative orthodontic treatment. Generally, orthognathic surgery is recommended to non-growing patients with larger dental-skeletal discrepancy, while dental-alveolar compensation or camouflage is recommended for milder discrepancies. However, as to which treatment should be chosen is not always an easy task, especially in borderline cases, while the decision is up to the patients. Many patients here refuse the surgical option due to its costs and the invasive nature of the procedure. So a camouflage treatment will be chosen to attain acceptable occlusion, function, and aesthetics through dental alveolar compensation for the skeletal discrepancy. In our faculty, patients may refuse the surgery option mostly due to the invasive procedure. However, due to the updated information nowadays, patients have started to look for the alternative of having a surgery. Now, today's topic is about the orthodontic treatment in adult patients with class 3 malocclusion with orthognathic surgery or with camouflage. And here, case 1 is treated with orthodontic treatment and orthognathic surgery, while we have the class 3 malocclusion accompanied by asymmetry, and the treatment is single jaw surgery, which is the mandibular setback. The patient came with the chief complaint of unable to bite in the front teeth, and then he also had the complaint of her chin is being deviated to the left. Before treatment, we have the intraoral, and we can see there's an open bite, molar to molar. And then the cephalometry is shown from the frontal side and the lateral side that the asymmetry is deviated to the left. This is the treatment of pre-surgery. And then what we did here is to decompensate, to prepare for before the surgery is done. And then this is the after orthognathic surgery. And as we can see, the bite is actually quite nicely being made. And then as we can see that before and treatment, before orthognathic surgery and 3 weeks after orthognathic surgery, the profile of this patient is corrected nicely. This is the way the patient smile. As we can see, the open bite is getting better, especially 3 weeks after orthognathic surgery. We still use the elastics to correct all the bite, the dentition, the malocclusion left. This is the extraoral profile. As we can see, it is much better. And then from the lateral side, you can see that the mandible has been set back nicely. The panorays show that the root paralleling is very nicely and then as you can see, the result of the orthognathic surgery is also give the result nicely. And then this is the lateral cephalometry. As you can see, actually in this patient, we have the combination, not only preparing for the orthognathic surgery, we also intrude some dentition in the posterior side of the maxilla, and it will help how we make the plan for the surgery. So because we have this intrusion in the posterior side of the maxilla, we are able to make only one surgery, one jaw surgery, which is in the mandible only. after debone, as you can see, patient has a very nice smile, a very nice profile, and the mandible is still in a good position. And the dentition here, the intraoral, is shown that the patient is having a very nice occlusion. This is the case 2 treated with the Lefort 1, BSSO, and anterior subapical osteotomy and genioplasty, because the dysplasia is very very big. So we have a mandibular hyperplasia here. And then this is the patient before treatment. And as you can see, the open bite and the dysplasia in the mandible. Yeah. And this is the occlusion before treatment, which is the intraoral can be seen that the patient are not able to bite from premolar to premolar. And then this is the cephalometry and panorrhea before treatment. And this is after we do the treatment before the surgery. As you can see, we also make the combination to intrude the posterior dentition in the maxilla, because we would like to make sure that when the surgery is done, the patient can bite nicely. This is after she has the surgery. As you can see, she had a 5 piece of Lefort 1, and then she has given a lot of very good result. As you can see here, the patient after the orthognathic surgery can have a very nice occlusion. Unfortunately, even though this result is very good, the patient is not able to continue until the debone because she had cancer and she passed away. But anyway, this is her last visit, which is actually she had a very nice occlusion. And then this is pre-operation and post-decompression and post-operative cephalometry. And this is the panorrhea. As you can see, the surgery was done nicely with so many techniques. It is really a good opportunity to see this many techniques in this patient. So this is the comparison. Now is the case 3, when this patient is having asymmetry, and then she had the single jaw surgery with the mandibular setback. Why? Because this patient had the difficulty with the cos. So she is only able to have a single jaw surgery, even though actually she needs 2 jaw surgery. So as you can see, she had a quite deviated symmetry with the deviated chin to the right, even though she already had the setback. This is her debone phase. This is what happened because actually the maxilla should be corrected with the impacted with the correction of the occlusal plane in the maxilla. So you can see there's still a canthing in the maxilla, but in the dentition actually it works nicely. And then this is an extra case, even though this is not an entirely class 3 malocclusion, but I would like to show because this patient had a condyle hyperplasia, and then she had the Lefort 1 and condylectomy, and then genioplasty. At first, she was going to have also BSSO, but in the end, after the condylectomy was done, the occlusion has been corrected nicely. So this is before treatment. You can see that there's a hyperplasia in the condyle in the left side. So the chin is deviated to the right. And then if you see, the occlusion actually is okay, but if you see from the treatment, you can see the cephalometry and in the lateral and frontal and panoray shown how deviated the mandible is. This is after orthognathic surgery, and then you can see she has a very nice profile. So what happened here is she had the condylectomy and the genioplasty and the livort one, so it works nicely. And then this is after debone. But sometimes patients won't have the surgery because of like the invasive procedure. So some patient would like to have only camouflage. So this is the patient with the camouflage treatment. As you can see, this patient should have been corrected by surgery. And then even though we do not perform the surgery in this patient, but the combination with using mini screw to intrude the posterior dentition can give very nice quote unquote profile. So you can see the dentition also works nicely. And then in this patient, which is still in progress, she also preferred to have non-surgery or camouflage. And as you can see, the dentition actually works nicely. So as the summary, the age of the patient, the severity of the malocclusion, patient's chief complaint, clinical examination, and cephalometric analysis will delineate the treatment of choice. The severity of class 3 malocclusion in adult cases will define whether the patient is suitable for surgery or orthodontic treatment. Generally, orthognathic surgery is recommended to non-growing patients with larger dentoskeletal discrepancies, while dentoalveolar compensation or camouflage is recommended for minor discrepancies. However, the decision as to which treatment should be chosen is not always an easy task, especially in borderline cases, while the decision is up to the patients. This is for our acknowledgement. We have the dean, the new dean now, which is from our Department of Orthodontics, Dr. Nia, and the supervisors for these cases, Dr. Maria and Dr. Krishnawati, along with the residents that have been working very nicely to have achieved the good and optimum result for the patients. And this is also the Department of Orthodontics Indonesia. We are collaborating with the Department of Oral Maxillofacial Surgery Universitas Indonesia, and some of the patients are being operated by Dr. Leung Mai Kyu Young from the University of Hong Kong. That's it for today. Dr. Yossi, I believe I have reached my time. Thank you very much.
Thank you very much, Doctor. Actually, still have 5 more minutes, but thank you.
I start with my timer. It's already 15 minutes.
Yes, thank you very much, Dr. Sari Sandi. It's a very nice presentation. It's a very interesting cases that you already described. I mean, personally, I have a question, but I will wait until the last sessions of the today's meeting. Okay. Thank you very much for your presentation. We're moving to our next speaker from Erlangen University. I would like to introduce our next speaker, Dr. Gigi Andra Rizkiawan, PhD, spesialis bedah mulut dan maxillofacial consultant, born in Surabaya, September 1981. He is now a lecturer in Faculty of Dentistry, Erlangen University. I would like to congratulate Dr. Andra first for being elected as a new leader of Indonesian oral and maxillofacial surgeon in East Java, if I'm not mistaken. Congratulations, doctor. Okay, I'm going to continue. Dr. Andra. Yes, Dr. Andra is was graduated from Erlangen University, dentistry in 2004, and then he reached his PhD program in Hiroshima University, graduated at 2013, and his specialist program from Erlangen University, graduated in 2015. He is now working as a staff in oral and maxillofacial surgery, Faculty of Dentistry, Erlangen University. One of his acknowledged publication is Stability of Tissue Augmented with Deproteinized Bovine Bone Mineral Particles Associated with Implant Placement in Anterior Maxilla. Okay, Dr. Andra, please, the time is yours. Your time is 20 minutes for presentation. Thank you.
Yes, thank you very much, Dr. Yossi, for the nice introduction. So good morning, everyone. And here I can see my senior and my colleague, Professor Narmada, Dr. Arbi. How are you, Dr. Arbi? Dr. Vera, and then I can see Dr. Maria from University Indonesia. Thank you very much for attending this meeting. Please, I would like to share my presentation. Okay, can you see my slide, Dr.?
Yeah. Yes, we can see your slide. Please continue.
Okay.
Thank you, Doctor.
Thank you very much. So, good morning, ladies and gentlemen. Let me introduce myself. My name is Andra Rizkiawan. I'm from Department of Oral Maxillofacial Surgery Universitas Erlangga, Indonesia. In this opportunity, I would like to share my presentation about the surgery first approach, or as we know as SFA, versus the orthodontic first approach, or OFA, in the class 3 skeletal malocclusion narrative review. For the background, based on the study conducted by Lee et al., show that 86% of orthognathic surgery patients with a class 3 skeletal malocclusion. This class 3 skeletal malocclusion is a condition which is the mandible experience the prognathism. The most common type of acromal skeletal, the mandibular prognathism with neuromaxilla, it's approximately about 43%. And maxillary retrognatism with a normal mandible around 90.6%, and the combination of both less than 5%. Based on the treatment method, currently the orthognathic surgery is divided into two methods. First, the surgery first approach, and second, the orthodontic first approach, or OFA. As we know that the SFA method differs from the terms of the sequence and the stages of treatment, which of course cause the difference in the duration of treatment as well, which affect the patient quality of life and post-operative stability for the patient, and also ultimately affect the level of the patient's satisfaction. Many arguments about the SFA methods are the same as when the OFA method was first introduced. In the group that are currently against the SFA method, they say that the SFA method has a narrow indication and the possibility post-operative relapse is greater than OFA method. Therefore, in this review, I will examine the both methods, which I will discuss further on in the next slide. The review method. So the source of the review is source are the secondary data in the form of journal, scientific article, and the case report. For the research strategy, the database come from PubMed and Scopus with the keyword orthognathic surgery, surgery first, orthodontic first, class 3 malocclusion, duration, quality of life, and post-operative stability. This research limited to the article in Indonesian and English, and the journal publication is maximum of 10 years ago. For the final research, we got the 22 journal in the form of the research report and the case report. And for discussion, the class 3 skeletal malocclusion correction is the most common reason for the patient undergoing the orthognathic surgery. The pre-orthodontic treatment on OFA have a long duration and decline in the oral health, digestive disorder, and socio-physiological problem. But in SFA, or surgery first approach, we have a short duration without the pre-operative orthodontic treatment was eliminated and utilized by RAP, regional acceleration phenomenon. But still have a question mark, the post-operative stability. Based on the research conducted by Wang et al., Jung et al., and Zhai et al., and Zingler et al., prove that SFA method has much shorter duration than OFA. And for the goal of the pre-operative orthodontic treatment consists of coordination of the dental arcs, the elimination of the crowding, and the restoration of tooth inclination. On OFA cannot be done maximized. And the regional accelerate phenomenon, or RAP, on the SFA can increase the bone remodeling after refracturing of surgical procedure as seen in the normal bone turnover. And why the SFA method is faster? So first, because of the RAP, the regional accelerate phenomenon. So the surgery triggers increase the osteoclast activity and dentoalveolar metabolic change at 3 until 4 months post-operatively. This makes the metabolic activity of soft tissue and bone increase accelerate the tooth movement. It can make the efficient post-operative orthodontic treatment. And the maintenance of the skeletal and soft tissue imbalance prior to the initiation of the tooth movement in SFA. So the absence of the decompensation on the SFA make a skeletal and soft tissue imbalance are maintained and correct surgically. Thus, in the post-operative orthodontic treatment, orthodontists move teeth in the normal skeletal and soft tissue condition. This can make facilitating the orthodontic movement. Every research say that SFA method could be complete within 2 years. The different treatment depends on the host factor, depends on the malocclusion type, patient age, the presence of crowding tooth, anterior posterior transverse and vertical compensation, key recompensation rate, the patient biology response. And for surgical factor, the amount of the mandibular setback and advancement, fixation method, the surgical method, and muscle adaptation. If there is a tooth extraction, it might be tooth mobilization might occur for the some time. It makes the longer duration of the treatment. In this slide, I will explain about the questionnaire for quality of life in orthognathic surgery patient, such as the orthognathic quality of life questionnaire, or OQLQ, can evaluating patient quality of life after surgery, and oral health impact profile, or OHIP 14, to assess the patient quality of life and related to oral health, and dental impact daily living, the IDL, to measure the patient satisfaction and effect of the dental disease on daily living, the patient health questionnaire, or PHQ-9, to measure the evaluating patient depression in various clinical stats, and the generalized anxiety disorder questionnaire, a screening tool for generalized anxiety disorder, panic disorder, social anxiety, and post-traumatic disorder. For the result of the OQLQ, both for the SFA and OFA method, are significantly improved in the 6, 3, 1 month, and immediate after surgery. The compensation can cause the patient frustration in the long term of use orthodontic appliance and discomfort in the masticatory function. Therefore, we must inform consent the patient regarding the condition they will face in the future. In the more detail, in the study using the OQLQ, all of them show that SFA improving the social aspect, greater improvement on the facial aesthetic compared to the OFA, and similar oral function, keep quality getting better for 6 until 12 months post-operation. In the BHQ9 and G87, there is no improvement on the anxiety and depression level at the 6-week and 6-month postoperative. And for DRDL, SFA method could offer better satisfaction compared to the OFA method because of the rapid improvement on the facial aesthetic during early period of time. The SFA method is the more advantageous in the term of preventing quality of life degradation at the pre-operative compared to the OFA method. The SFA method improved in the facial profile can be felt immediately in a short period of time. So patient satisfaction tends to be greater in the SFA method than the OFA. According to the Sagavi et al., patient motivation also affects the orthognathic surgery method. If the patient take notice of the occlusion quality instead of facial aesthetic, they have choose the OFA method. And if the patient take notice the facial aesthetic more than other aspect, they have take the SFA method. Next is the post-operative stability. Post-operative stability itself is closely related to skeletal relapse, the MJ discomfort, muscle contraction, maxillary contraction, curve of speed, the amount of the overjet and overbite, condylar resorption, condylar displacement, and remodeling. For the term of the temporomandibular disorder of TMD, there is no significant difference was found as a TMD post-operative. Next is the displacement of the condyle. So the displacement of the condyle itself actually a normal process. The third that after orthognathic surgery. The difference between people and the method in the magnitude and in the direction. The difference may do the presence of the maxillary movement can affect the mandibular rotation. Clockwise rotation of the maxilla can improve the skeletal stability. And the use of spleen in the SFA patient to achieve more stable occlusion can lead to the mandibular auto-rotation when spleen is removed. In addition to the condylar displace, there is also condylar remodeling, which is believed to affect the skeletal stability and relapse. The etiology of condylar resorption after the orthognathic surgery is still unknown. However, there are several studies that explain the forced position of the condyle during the surgery and the tension in the muscle, periosteum, and the ligament after surgery cause substantial stress in the condylar head, especially in the form of compressive force, thereby the stimulating condylar remodeling and even skeletal relapse. In addition, there are also those who say that the rotation of the condyle inward after mandibular setback result in the remodeling of the condyle. The absence of the pre-operative orthodontic treatment on the SFA can causing occlusal instability. Some paper mention there is no significant difference of mandibular relapse between the SFA and OFA, and some paper mention the SFA have a greater relapse. The cause of the difference of the mandibular relapse amount first because of the mandibular auto-rotation after surgery, spleen or orthodontic bracket removed. Second, the SFA more vertical reduction due to the vertical bite settling after orthodontic surgery. Third, the difference in distribution of the facial type in the patient. According to the Park et al., Kim et al., and Ko et al., SFA had a more high relapse cases than the OFA because of the absence of the pre-orthodontic treatment. Therefore, some studies suggest pre-operative orthodontic treatment could be performed on the SFA method for about 1 until 3 months minimum. It's called the modified SFA. This purpose to remove the several occlusal interferences, resolve the major crowding in the maxillary anterior teeth, and the coordinate the maxillary and the mandibular arch, especially in the case with intercanine with wide discrepancy. Many factors to make the skeletal and dental relapse after orthognathic surgery, such as the large overbite, deeper curve of SPI, greater negative overjet amount of the setback. Therefore, relapse needs to be taken into post-operatively by conducting accurate analysis of each case and sorting out the most suitable case according to the SFA method. Other important factors that could affect the final result of the surgery. First, the occlusion setting after surgery, the movement of the teeth to minimize the occlusion interference, the mandibular movement due to the counterclockwise rotation of the mandible after surgery, face shape, the shape of the dental arc, occlusal guidance in the SFA method relies totally on surgical spring, the use of chin cup and orthodontic elastic, and the use of the computer-assisted virtual surgical simulation and virtual surgical planning. And in the study, we have several limitations, such as the heterogeneity in the method, statistic, technology, and patient sample, including the ethnic, race, and culture. And clinical finding of each case study analysis become more unreliable. Prospective study that are better designed, standardized, systematically, and proper report with a more homogeneous patient and adequate duration are needed to provide in the best result. And for the conclusion, the SFA and the OFA method are two different orthognathic surgical protocol. It's different with indication and order of the treatment. So it is necessary to plan the proper treatment by surgeon and orthodontic by utilizing the existing digital technology such as 3D analysis, so that the correction result can be predicted, and the end we can reduce the occurrence of the relapse and the patient quality of life can be better. This is the end of my presentation. Thank you very much for your attention. We're back to Dr. Yossi.
Thank you very much, Dr. Andra. 15 minutes, exactly. Okay, that's all our presentation, our three speakers for today. We still have about 23 minutes left for discussion. So I would invite the audience, or maybe distinguished participant who maybe have a question according to the presentations of our three speakers. If I may, I want to start with my question, maybe to Dr. Andra. Dr. Andra, your previous explained about the possibility of the condylar movement that perhaps could affect the temporomandibular disorder that could happen, which is we already know that one of the problem of the patients with malocclusion, even skeletal or dental problem that going to undergo an orthognathic surgery, mostly have a temporomandibular disorder. So how about the follow-up after the orthognathic surgery, about the TMD that already happened before? Thank you.
Yes, thank you very much for the question, Dr. Yossi. Yes, so the big problem of post-operative orthognathic surgery is the TMD problem, I think. So therefore, we must during the surgery, we must put the condylar position in the normal position before we put the plate, or we put the fixation between after we do the EPSSO. And
so we have to make sure that it's in the inside of the fossa glenoid before we do insert the plate.
Yes, so I mean that we have to make the position into the natural position, Dr. Yossi. So if we cannot, or if we have the problem in the TMD problem after post surgery, we have to maintain, and maybe we can coordinate with the orthodontist to make the occlusion more stable, so can make the pain in the TMD is less.
Thank you very much, Dr. Andra. We have questions from our participant. Hello, Dr. Dr. Teguh Ahmad Arbi. Hi, Arbi. He have two questions. First is how long we would evaluate the orthognathic surgery result. Maybe to Professor Ruslin perhaps could answer the question. How long, in most cases, how long is maybe the duration that we can presume that this is the final result of the orthognathic treatment? Maybe mungkin itu ya Dr. Arbi, mungkin.
Dr. Yoshi, could you please to repeat again? I couldn't.
Okay, so the question is how long we would evaluate the orthognathic surgery results. So maybe at the time we think that the treatment is finished. How long in most cases?
Thank you. That is from my college, Dr. Arbi. Oh, thank you very much. Good question. So actually, to evaluate our patients after surgeries is for a long time. We have experience for the patients. We do research in Netherlands. We already follow up patient duration arrange is till 26 years. Because we would like to evaluate it about the issue is according to the stability. So we still control our patients, and then we make sure that is our technique or that is our a way to prepare to get a good occlusion, a good facial appearance, or good there is no complication after long-term treatment. So we already recall our patients and we do some sequentially, for example, the first years 3 and 7 and so on. So I think that it's more important because we would like to evaluate our technique, and also we would like to get information about the outcome of our surgery. Yeah, that is Dr. Yoshi. So we have experience
so
that
probably we can do the follow-up for the patient even until 7 years after the surgery.
Yeah, it's correct. Yeah, it's correct.
But how we decide that actually our treatment is already an optimum level? I mean we already do the best for the patients, and then the rest is we just have to wait until the result. How long or how we decide?
So actually we just saw the results because the technical is we would like to get some functional of our surgery. The goal of our surgery is the first is the functional, that is mean masticatory, and then the second is the aesthetic, and also the stability. And that is the key, is more important thing is about the stability. So if we would like to know about the stability, so we must to follow up our patients as long as we can to follow up our patients. That is Dr. Yoshi. Thank you.
Thank you very much, Professor. So as long as we know what to follow up, then we can we can actually evaluate the general result of or the outcome of our treatment in orthognathic surgery. So I would like to read another one. Okay, I'm going to continue to next question. Okay, this is from Ervina, North Sumatra University. Is there any special consideration for orthognathic team in treating the class 3 young adult patient with asymmetry and developing TMD? Young adult patients means still in a growth jaw, if I'm not mistaken, Dr. Ervina. Young adult patient means in still in a growth phase. Maybe to Dr. Sari Sandy, if you can answer the question. The patient is 21 years old. Oh, okay.
Yes,
she's already
I believe it's I believe young adult, maybe it's after the growing finish.
So
Okay.
it's around, yeah, around 18 to 21. For the consideration, actually, if we are working as a team, before the patient is being treated, if she or he has already developed a TMD, of course, if there's a pain, we also have to include the prosthodontist to treat the TMD first. So we have to make sure that actually the position is the optimum at that moment. And I agree with Dr. Andra that he said that during the surgery, the plan is to put the condyle in the neutral position in the fossa glenoid. Yeah, I think that is the answer.
Thank you very much, Dr. Sarasandi, for your answer. We have a participant raising hand from the North Sumatra University. Okay, please unmute. Okay, can we spotlight the video of the FKG USU?
Already spotlight.
Boleh di spotlight untuk yang FKG USU?
Yes, I'm here. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Yes, please.
Thank you very much for the chance to me to ask something about financial efforts from the orthognathic surgery in University of Indonesia. From maybe for Dr. Sarasandi, I am Erliera. Hi, long time no see. I would like to ask about the patients' effort to pay about the condition for orthodontic surgery. Is there any BPJS or ASKES or something that
Health insurance
Health insurance.
to cover
Health.
the surgery or the treatment of orthodontics?
no, the surgery.
The surgery, okay.
For the surgery,
Yes.
is there any like the BPJS can afford for the surgery, or maybe the patient should pay by themselves or something like that? Thank you.
That's a very good question.
Because we have some
Yes, it is always the questions.
Yes. The
And then?
financial problem for the whole treatment phases.
Yeah.
many of the patient came because to the institution because they want to pay a bit cheaper. Yeah, that's many patient rejects for the surgery because of that financial problem. So maybe if you could share about the finance, is there any possibility we can use BPJS or something like that?
Thank you very much for the question. I think all of our speakers have competence to answer the question. So who wants to answer this question?
Prof. Roslin, Dr. Andra.
Yeah, I think everyone here have a competence in answering this question.
Thank you very much. I try to answer the question is for me, my experience, all my patients with the orthognathic patients, they use BPJS. So we can use BPJS.
Yes. Maybe with specific diagnosis, Professor. I mean, in some cases, we have to put...
Yeah, we put it with the TMG disorders. It causes malocclusion. It causes skeletal discrepancy.
Okay, so we have to put the skeletal discrepancy and also the temporomandibular disorder. In case that if we hope that all the surgery can be claimed using national health insurance, kind of that. BPJS, Prof. Yeah. Thank you very much. Maybe Dr. Andra.
And also that is mean we not get a lot money, just small money. But we can get it the
Jasa
cases.
medisnya gitu ya, Prof. Thank you. How about it? Thank you very much. How about the orthodontics? Dr. Sari Sandy, is there any cases that the treatment of the orthodontics can also be covered by the health insurance in University of Indonesia?
Amen to that.
We hope that.
Yep.
Dr. Yosi, I think, yeah, the problem is the orthodontic treatment is not covered by insurance, right? So maybe, yeah, I can recommend it to have a treatment in the university hospital. I think it's
cheaper.
It's a little bit cheap. Yeah, it's a little bit cheap.
Thank you very much for the information. So we still have a question. The second question from Dr. Arti.
Dr. Yosi,
Yes,
a little bit.
yes, Prof.
According to the BPJS, for the orthognathic patient, for the orthodontist, I think they want to use BPJS, but we can try use like the others foundation, like NGO, non-government organization, like our activities labels club center. We can ask to the like smell train to pay for the patient for the orthodontist.
If it's a cleft patient that going to undergo
orthognathic patients.
Oh, okay.
Yeah.
One of the solution. Thank you very much, Professor, for your information. Yes.
I would like to apply for that, Prof.
Yeah, but it's special for the skeletal
train, right?
Only for the cleft patient. Only for the cleft patient.
Yes.
Yeah.
Oh, I understand that. Dr. Sari Sandy also have a thing to cleft patient. You have a presentations about the cleft patient as well, right?
Yes.
Orthodontic treatment in cleft patient, if I'm not mistaken. I read in your biography.
Yes.
Okay. Moving to the next question from Dr. Arbi. Okay, we only have like 8 minutes left. Dr. Arbi asked about the obstructive sleep apnea. So, do you have experience with patients after develop OSA after orthognathic surgery? Perhaps this is for the patient with the setback mandibula. Perhaps that it could compromise the airway. So maybe if there's any experience from Dr. Andra and also Professor Ruslan after the surgery, do the patients ever develop non-obstructive sleep apnea? OSAS, if I'm not mistaken, we can check by the OSAS.
Yes, for my opinion, Dr. Yosi. So there is a indication. So length of the maximum we can set back the mandible. So if we not over, I mean, I'm not mistaken, maybe at least 1 centimeter, right, the Prof. Ruslan, to have the maximum setback of the mandible.
Yeah.
Yeah, if we reach less than 1 centimeter or maybe 8 milli, I think it's no problem with.
Oh no, it's okay. Okay.
Less than 8 or maybe 10 milli, I think it's no problem with the sleep apnea.
Thank you very much, Dr. Andra. So I think the measurement before the surgery, the measurement that we plan to set the mandibular back before the surgery is very important as well, right? To avoid the OSA. Moving up to next question from Dr. Ahmad Setia Bakti. This is in Jakarta. Sorry for joining the discussion. Okay, I was done with one patient after orthognathic surgery with class 3. Nice result. Occlusions is back to normal. But after surgery, we detected lack of psychology from the patient. Patient still unhappy with the result. Become more satisfying about anything after the result, so the patient preferred to get another treatment with nose filler, etc. So the analysis of psychology is more important. The question is, what can we do? Can we put psychology consideration in the theme of orthognathic surgery? What do you suggest? I think this is for both Professor Ruslan and Dr. Andra. do you think that we have to put the psychology consideration to the orthognathic patient? Because in some point, maybe the expectations of the patient are really similar with the results of the surgery. I have no idea, probably.
Yeah, Dr. Yosi?
Yes, Professor.
Yeah, so that is one of the point is before we started the surgery, so it's mean we prepare the patients and then we discuss, and also very important to make a good preparation according to the psychology aspect. So it's need to consult to or we refer the patient going to the psychology to discuss about the their chief complaint according to the maybe malocclusion or appearance of the facial of the patients, because that is a very interesting point of the psychology aspect, because some of patients after surgery they not receive what happened after we do surgery, because some of patients have they have its mean is like
psychological something.
Psychology apa harapan expectation. They have very high expectation according to the surgery, but sometimes if we do surgery it's not the same, so it's meaning the patient must be consultation, or we refer to the patient for the psychology to discuss about the problems.
Thank you very much, Professor. Dr. Ahmad
in Amsterdam, that is one of the mandatory for the patient, because some of patient maybe just would like to show some like different appearance of the facial before surgery and after surgery, so they must to make like some discuss to the consultant according to the psychology aspect. Yeah.
Thank you, Professor. Okay. I hope the Dr. Ahmad Setia Bhakti satisfied with the answer, because I have to move to another question. This is from Dr. Maria Purbiati from University of Indonesia. This is for Dr. Andra. A long-term stability is also our purpose. Is there any procedure for muscular after the surgery procedure? Is there any specific procedure for the muscle, maybe after the orthognathic surgery?
Yes, thank you very much for the question, Dr. Maria. So in this study, a lot of study by another person, so there is no long-term stability. Still do a research of the long stability. So I mean that, so it is a good idea to have a research with the long stability in the after the orthognathic surgery. Yes, thank you very much for the question, Dr. Maria.
Thank you very much, Dr. Andra. So it's not really conclusive. Is there any specific procedure? Okay, there's a question. This is from Hassanin University, one of our residents, about the quality of life for the patients. How about the satisfaction evaluation for the patient with complications of neurosensory disturbance? Is there any specific effect in the assessment of the quality of life for the patient?
Yes, I believe if we talk about the neurosensory disturbance, it's very disturbing for us. I mean that even though in the operation of third molar, since sometimes we can get the what do you say, paresthesia, is also can make neuro
injury.
Yeah, I believe the quality of life is become decreased if the someone who suffered from neurosensory disturbance.
Thank you very much, Dr. Andra. Actually, we have our time is up, but we still have one more question to answer. This is from a resident of orthodontics from Hasan University to Dr. Andra about the choice of the surgery first and orthodontic first. So what approach that most effective according to you depend on the cases? Thank you. This is the last question.
Yes, thank you very much for the question. I believe that so there is an indication and contraindication for the surgery first or orthodontic first, such as for the surgery first, at least there is a three stable occlusion stop between the two arcs. This is the indication, and the mild and the moderate curve of SPI, mild vertical problem. And for the contraindication for the SFA, we have a severe crowding requiring the extraction, so severe asymmetry, anti-MG problem, and the class 2 deficit 2 occlusion with the overbite. That is the indication and the contraindication of the surgery first approach. Thank you very much, Dr. Yosi.
Thank you very much, Dr. Andra. Thank you very much, Professor Ruslin. Dr. Sari Sendi, this become a very great session, and thank you very much for sharing your knowledge and experience. From Komatsu Sensei, this is a question for the organizer and chairs. How are you able to attract so many people? Congratulations. Well, actually, we have a very great participants and audience out there. Thank you very much. Thank you very much for the speakers and also the participants that already joined. I would like to close the session and I would like to return this to Dr. Aksa. Thank you very much. Good job, everyone. Please, Dr. Aksa.
Thank you, Dr. Yosi. I think everyone here has experienced good atmosphere of seminars. We received some beneficial from these sessions, and I would like to thank for the speakers here, Professor Ruslin, Dr. Andra, and Dr. Sari Sendi, and we will meet again in the next session in Apan 55. Thank you very much and goodbye, everybody.
Thank you very much.
Bye-bye.
Thank you.